We now move to a special joint session with the ATLS Region 16, the collective of ATLS course providers in the Asia-Pacific region. This session captures the evolution of trauma care, from Sri Lanka's own decade-long journey of innovation and capacity building to the visionary outlook of the American College of Surgeons Committee on Trauma and the global expansion of trauma preparedness through the Rural Trauma Team Development course.
It's a celebration of progress, partnership, and purpose. To guide us through this vital session, we warmly invite on stage Dr. S. Sang, Consultant Surgeon at the Department of Surgery, University of Hong Kong, and Deputy Program Director for ATLS Region 16, Hong Kong.
Gentlemen, it's my honor to be chairing this session, which is titled Trauma Care Without Borders, Standardizing Training, Elevating Outcomes. And from Hong Kong, China, I send you my greetings. And I'm very honored to be invited to your prestigious conference. Let me introduce the first speaker. Dr. Kirti Abayajeewa, who is the Consultant General Surgeon at the National Hospital of Sri Lanka, who is also the Country Chair of the Advanced Trauma Life Support Sri Lanka, and member of the Editorial Board of the Trauma Journal of Sri Lanka, Academic Chair of Trauma Conference in Sri Lanka. And he's going to give us a talk on ATLS in Sri Lanka, Shaping Trauma Care Over a Decade.
Right, very good morning to you again. The ATLS team, ATLS gathering, and also the trauma conference delegates. So as we know, we are celebrating almost the 10th year having ATLS in Sri Lanka. So we started in 2016. Actually, this was the first email sent across to Professor Holland, the ATLS regional chair in 2016, and copied to Gilberto as well. And the contact was given to us by Mr. Chu Min Turk of Singapore, who was the country head at that time in Singapore. And then we had the problem of funding. So the Ministry of Health came forward with this World Bank fund called the Health Sector Development Fund, and also the College of Surgeons to supply the logistic support. There are three persons I should mention who was behind the starting of this the ATLS program in Sri Lanka. Dr. Ranjan Dias was the College of Surgeons president in 2016, and Dr. Palita Mahipala was the Director General of Health Services, and also handling this project was Dr. Champika Wickramasinghe, who was Deputy Director General at that time. So the site visit was undertaken in 2016 by Professor Mike Holland, Dr. Gilberto Lang, and Ms. Leslie Dunstall of the Region 16, and we signed the MOU on July 19th of 2016. Right. And then, of course, our first ever program, after the site inspection, the College of Surgeons was decided to be the first site for the ATLS, and the program. The first program was on May 15 to 17, 2017, and the first ever instructor course we had back-to-back from 19th to the 20th the same month. So there's some of the pictures from the event. And currently, we run 2 centers, the College of Surgeons of Sri Lanka and also the National Hospital, the biggest tertiary hospital in Sri Lanka, that is under the Ministry of Health, the Trauma Secretariat, which is also the sponsor of the National Trauma Conference. And we have had 31 student courses and 4 trainer courses. We have trained over 491 doctors over the last 10 years. We have 36 instructors and 1 educator and 4 nurse coordinators. So our country is not a big country, as you know. It's 64,000 square kilometers with a population of 20 million. So though the numbers don't look that big, but the impact has been quite profound. So what are the other sort of collateral impacts of the ATLS in Sri Lanka? We developed this course, the National Primary Trauma course. As we know, the ATLS is held in Colombo, and in the rural part, it's sometimes difficult for the doctors to come to the center, and also the cost is significant compared to the local standards. So we devised this one-day program based on the ATLS principles, which the lectures as well as the workstations happening in a single day. It's a quite intense program starting from 8 o'clock, goes on till 6 p.m. And this program was funded by the Ministry of Health, and this also trained nurses and doctors side by side. We have had more than 20 such courses and trained a lot of doctors in the rural areas. And you can see the inside, there is this bus accident which happened a few months back, where a bus veered down a precipice and of 100 meters, and 21 killed as well as 40 injured. So one of the catchment of this, we had happened to hold a primary trauma care course just before, about 2 weeks just before the incident. So most of the patients who would have survived would have benefited from our PTC course being held there. Right, this is one of the landmark publications we did. It's called the National Trauma Manual, the first ever manual in Sri Lanka. It is the official manual of the Ministry of Health, and this manual is also used as the base for the primary trauma care course that I mentioned. So this was entirely done, not entirely, mainly done by all ATLS instructors, and also this manual is somewhat different from the ATLS manual, the 10th edition. So we only have the practical aspect of the ABC and the rest of the injuries. And we have thrown in, apart from the surgical aspect, we have seen into chapters on the medical legal aspect of trauma, etc. So this is quite a comprehensive manual that is widely used in Sri Lanka as the base of trauma care. Right. Also, we did a series of video presentations, though there are so many videos like if you go on YouTube, but we had these video productions because we thought it is to link it with the trauma manual, as well as to be more familiar to our local doctors and nurses if we have the sort of familiar faces. So this series of videos we produced and available for viewing. There's about 20 videos in that, such as intubation, intercostal drainage, cricothyroidotomy, and other procedures. And this was again entirely done by our ATLS team. Right. So apart from training doctors, the trauma module of the University of Colombo has been adopted and also officially sanctioned by the American College of Surgeons to have according to the ATLS principles. And I was told by Professor Siva Ganesh, who is the head of surgery in Colombo, that the module has been adopted by 2 other universities. So this is also a side effect of the ATLS program in Sri Lanka. And our educator, Professor Pandula, is the educator at the Postgraduate Institute as well. So he has divided the Train the Trainer course, adapting the principles of the ATLS trainer course. So this also is one of the other benefits that we have had on the system in Sri Lanka. So in the outcomes, when we talk, so the ATLS has helped us to benchmark our trauma care throughout the main centers as well as the peripheries. And though we are not audited the outcomes, definitely there should be better trauma care before and after the ATLS program was started in Sri Lanka. And education-wise, in both undergraduate, postgraduate, and postdoctoral level, the standard of trauma care in the education is standardized based on ATL principles. And in the rural Sri Lanka, as we do as an outreach programs, as I mentioned earlier, the effects of the ATLS is not only benefiting the centers, but also rural hospitals in Sri Lanka. And ATLS is run by, as we know, multi-specialty surgeons, anesthetists, critical care specialists, emergency physicians, so on. And there's a fairly good partnership or fellowship between the multi-specialties, probably because of the ATLS course being held together by these specialties. And we have also developed quite a good international network starting from the ATLS, being part of regional conferences, and now within the 10 years of starting, we have had the regional conference in Sri Lanka. So that is one of the other benefits that we had, which invariably helping to share our knowledge and to gain new knowledge through our regional partners. Right. So thank you, and thank you. I would take this opportunity to thank all the ATLS delegates who came here for our regional conference, and I hope you enjoyed yesterday and hope have gained fruitful day today as well. So thank you very much.
Sorry, there was a problem with the microphone. The second speaker is Dr. Narain Chotrosnaramit from Thailand. Dr. Narain is basically eponymous with ATLS in Thailand. He is the chief of the ATLS program in Thailand, and he's also the dean of the Faculty of Medicine of Chiang Mai University. And we are honored today to have him share with us the trauma training in Thailand. So welcome.
Yes. Thank you very much, Simon, for your kind introduction. This is my third talk for this conference. It's going to be my last talk. Anyway, I have nothing to disclose. And I live in Thailand. You know, Thailand is Thailand, it's not Taiwan. When people ask me where you're from, I'm from Thailand. Oh, Taiwan, I used to be there. But Thailand is Thailand, not Taiwan. I live in the north. It's just the northern part of Thailand, north from Bangkok, about 700 kilometers. And actually, we pretty same as Sri Lanka because we have 95% Buddhists. In Chiang Mai, we have more than 12,000 monks and more than 1,000 temples in Chiang Mai. Because we have so many kinds of tourist attractive areas. We have corporate show, we have crocodile show, we have elephant drawing. Same as here, you have a lot of elephants. But a little bit different because we have elephant panda in Chiang Mai as well. Because we have giant panda and so many people want to look at panda. So we paint elephant to be a panda. And also we have a cute tiger, very cute, looks like a tiger. We have it in night safari in Chiang Mai. I did not come for invite you to Chiang Mai, but anyway, please be there and visit those places. And also we have motorcycle. Yes, we have motorcycle, a lot of motorcycle. Helmet wearing rate is about 50 during the day. During the night, 10-15%. So we do have a lot of motorcycle accidents. This is the statistic. 80% of our customer came from motorcycle. And also, people during the COVID-19, they're afraid of COVID-19. They wear a mask, surgical mask, without helmet. And even my medical students just don't wear a helmet. It's culture. So we have to make prevention and culture of knowing what harmful is. This is in the nighttime. Some video clip at the junction. We have a lot of car accidents during the night. So, but anyway, this is the reason why when the WHO report the traffic accident death rate, Thailand used to be number 2 in 2015 of the highest traffic accident death rate. And we can improve a little bit every year until now, 2023, we are in the rank 18. We still have about 25.4 per 1,000 population death of the traffic accident. Still have a gap to go. Singapore very low, a well-developed country, very low. But in Thailand, we still higher. I think highest in the Asia, I think. And I live in this hospital, as I mentioned, and already told you that this is my hospital, 1,400 beds. We belong to Ministry of Education. And we also work very close with the college, Royal College, Internal Medicine, Royal College of Surgeons of Thailand, Royal College of Physical Therapists, and so on, because we have so many training. My hospital is look very, very white, but actually it's not that white, because I just use the Photoshop to make it white for you to see my hospital is there. My emergency room, we accept the trauma case. It's not that high. It's about 16 to 20,000 visits per year, and the admission is about 2,000. But the majority of the case in my hospital, about 40% is major injury. ISS score more than 15. So we have a lot of bad injury. When we talk about the training, in Thailand and also in Chiang Mai, we have the program that we call residency and fellowship training. Belong to the Medical Council of Thailand. Medical Council is the owner of every training course, MD, specialist, but they deploy the curriculum to the college. So the Royal College of Surgeons of Thailand, they have the committee for training in every kind of subspecialist. So we have general surgical training, and we have the trauma surgery fellow. For general surgery, it's a 4-year curriculum. We have about 35 training centers, and we train about 160 surgeons per year. Our population is about 70 million people. So we train new surgeons about 160 per year. The curriculum is 4 years. And in this kind of curriculum, there are 5 months of trauma surgery rotation. Enough or not? Probably not enough. So we have another one we call the Trauma Surgery Fellowship. It's another 2 years curriculum. After you graduate to be a general surgeon, you go another 2 years to be a trauma surgery fellowship. But we do not have so many centers. We have about 5 training centers in Thailand. So we produce just not more than 10 trauma surgeons per year. Which is a very big gap for trauma surgery in Thailand. So we also accept some international fellowship. It's short period of time, about 1 year. So we got some from Singapore and Malaysia last year. For the training of the pre-hospital, we do have the ATLS. On the beginning, there's no institute to take care of the education for the pre-hospital, not officially. So this is the reason why when I worked with the college at that time, I think that we should have the pre-hospital trauma life support. So we just negotiate with the A.N.K and ACS to bring PSTOS to Thailand since 2015. So nowadays we train the doctor, nurses, paramedic, EMT, and this is the first course in Thailand. We have run 5 centers in Thailand. And nowadays we train more than 10 to 15 courses per year. The second one, we have a short course for nurse we call emergency nurse practitioner. It's a 4-month course for the nurse who work in the ER. They can come to our center for 4 months to train to be the emergency nurse practitioner. They're gonna know how to do the work in the EMS. They're gonna know how to take care of patient in the ER, and they're gonna know how to take care of the patient during the referral ambulance. So we got about 7 to 8 centers who train this. And also we have bachelor degree of paramedic. In Thailand, we start paramedic very late in 2009. And nowadays we produce paramedic about 200 graduate students per year. And we have just 7 training centers all over the country. So nowadays, who go with the ambulance? Normally, it's the volunteer, we call the first responder. 80% run by first responder. Another about 15% going by nurses, and 5% go by paramedic. And some doctor also jump into the ambulance and go with the team as well. So we still have a gap. So majority of the advanced case in emergency medicine, we still use the nurse who get trained to be the emergency nurse. So for the emergency room, we do have, yes, we have ATLS. Since 2003, it's 22 years already in Thailand. Just a junior brother from Australia. The starting guy came from Australian College of Surgeons, come to help us. This is the first course in Thailand, 2003. I'm the one in the arrow. You can see me. I used to be a very thin, smart, and young at that time, long hair. But now I'm old, fat, and not so energized. Thank you very much for the Royal College of Surgeons that come to help us, and also the American College of Surgeons to bring ATLS to Thailand. Now we are moving to the 11th editions. This is the reason why I'm here together, because I'm chair of ATLS, and some of our educator and coordinator come here. And thank you very much for coming here. And nowadays, ATLS run by Royal College of Surgeons of Thailand, and it's a compulsory for the general surgery, surgical training residents have to get trained before you go for the examination, you have to have the certificates of ATLS, otherwise you cannot pass. Also for the orthopedics and the emergency medicine, they have to. This is the reason why we have a lot of courses and a lot of centers in Thailand. We have about 15 centers of ATLS all over the country. And we train about 40 to 50 courses per year for our residents, both general surgery, emergency medicine, and orthopedics. And we also have the training, the diploma type board of emergency medicine is 3-year curriculum to train emergency medicine. So we train since 2003, the same year that we have ATLS in Thailand, actually. And also we have ATCN course for the nurse. It's a short course, 2 days, 3 days. Get along with the ATLS. This run by the Society of Emergency Nurse Thailand. And also I mentioned yesterday, we have a course we call Advanced ACAAT. This is a course for air ambulance that we still teach every year for sending the patient by air. And also we have critical care nurse course for 4 months to take care of the patient in the ICU. For the surgical skill, we do have the DSTC, but we stopped it for a long time since COVID-19. Since 2006, we started to have that by Royal College of Surgeons of Thailand as well. There are 4 people go to New Zealand to take a course. I'm the one at the right lower corner. I'm the one who wear the white shirt. That one, I'm older a little bit compared to the ATLS first course. And also thank you, Scott. You came to Thailand since 10 years ago, together with Ken Buffett and Ian Seville to teach a DSTC course in Bangkok. Also, we do have the ASSET. We have ASSET course since 2013. It's a cadaveric training for the anatomical exposure. So we have it for 12 years now. First person who come to Thailand is Dr. Mark Boyer and Deborah Cruz. Bring the ATLS to Sirat Hospital in Bangkok, back to back, and we also produced the instructor at that time. So we do the cadaveric anatomical exposure, and now we spread all over the country. We have about 6 centers all over the country, and do the training course like this in the north, which is in my center, in the northeast, in the south, and 3 centers in Bangkok. This is some photo of the cadaveric workshop that we have. Also in my center, in the northern part of Thailand, we also have ASSET course. We got donate body, about 600 body per year. Some of the cadaver go to the student. Some of the cadaver go to the research. And some of them come to the cadaveric training center to do the workshop, also ASSET course, and some course for orthopedics as well. We use the frozen cadaver. When we get donated body, we bring in the deep fridge, minus 20 degrees Celsius. And we want to use, we just have to bring out from the freezer about 1 or 2 days to let it thaw. After it thawing, you can use this body for the workshop. This is our facility, the center. So every general surgical resident have to pass this course just in my center, because they all have to learn and get the examination for the ASSET, because otherwise they cannot do the trauma surgery. Sam, this is some of the picture of the cadaveric workshop that we have, such as the X-ray artery exposure. The tissue is very fresh. You can see the vessels, muscles. Sometimes you can see still have some blood inside the vessels because it's the frozen cadaver. This is some footage of the resident doing the median thoracotomy. Median sternotomy, so sorry. We use the lift sketches knife for the resident to know how to do it and what is the anatomy that you have to take care of with the instructor. So we do it 4 tables for 1 course, 16 participants. And also this is the thoracotomy in the cadaver. Also the resident have the chance to do the thoracotomy, emergency room thoracotomy, even do the camshell incisions. So we do this every year for our residents. And also we have the reward training together with the 2nd edition of the ASSET course. Teach the resident how to do it, know the instruments, how to put the guide wire, how to do the dilator, put in the balloon. And with this course, make the confidence of the residents much more, especially the chest surgery. After they get the ASSET, they know about the anatomy. But the thing is, the ASSET, the course in Thailand, we do about 3 or 4 courses per year because it costs a lot of money as well. In my center this year, I do 2 courses for the resident and also open for public. But you know, when we open for public, it's quite requirement. I mean, the demand is pretty much. After I open half an hour, the course is full for 16 seats. And The problem of acid, there's no bleeding. So this is the reason why we have another one course for the resident we call the Advanced Trauma Operative course. It's animal lab to create the injury and bleeding. And residents have the chance to deal with that. So we do the acid first course, and then after that, 1 month, we do the animal lab for the resident to know how to deal with the bleeding, how to stop the bleeding. Same as this one who have the stab to the heart of the pig. We do the staple, we do the Foley catheter, temporary control, we do the suturing of the heart. This is how it looks like our animal lab. And we do have the instructor who can teach this course, about 6 persons help each other. This is the real situation after that. The resident have a chance, after they pass these 2 courses, they can do the surgery and can do this suturing to the heart. I am the one who holds the camera on the head, and my resident is the opposite side of me, suturing the heart, beating patient who has stabbed through the heart. And we allow them to do that because they passed these 2 courses already. So we do have some other courses, such as we have simulation for the ultrasound course for residents and medical students. We do have the ultrasound course for nurses. We do have laparoscopic workshop center in the cadaver and dry lab, also orthopedic workshop. So in the future, training, we're trying to make more interventions, radiology skills for the residents, also the minimal invasive surgery and the vascular skill. And we try our best to keep the WFME standard and make more acid costs to public and also bring back the STC in the future. Thank you very much for your attention.
Lorraine, for sharing your extremely prolific work in trauma education in Thailand. We leave the questions to the end. Now let's welcome the 3rd speaker this morning, who is Dr. Alisa Nagler and Ms. Julie Cwik. Dr. Nagler is the Assistant Director of Trauma Education Programs at the American College of Surgeons. And she's an extremely experienced educator in medical education. And she's had over 40 publications on medical education covering all areas of educational innovations, resident wellness, designing learner-driven curricula, et cetera, et cetera. And Ms. Cwik is the Instructional Design Manager of Trauma Education Programs at the American College of Surgeons. And they are going to deliver the talk on the American College of Surgeons Committee on Trauma.
Great, thank you. Good to see everybody. Technology pause. Should we get up and stretch? Great. So thank you for allowing me to share a little bit about what the American College of Surgeons Committee on Trauma has been doing related to trauma education. We're going to talk a little bit about ATLS 11, which you've heard a couple of times throughout the last couple of days. We'll talk about one of the conferences that we offer in the spring related to trauma education with an emphasis on our global partners. We'll talk about some of the other COT trauma education courses other than ATLS. We are going to celebrate 50 years of ATLS and want to talk about how we'd like to celebrate that and ask for your participation. And then a little bit about our My ATLS app. I'm clearly not. So yes, ATLS 11 has launched on August 3rd of this year. We still get questions, when is it going to launch? So I'm telling all of you right now, it has officially launched. We've only held a couple of dozen courses since that time. We piloted quite a bit, and thanks to those of you in the audience who helped pilot the course over the last year or two. So we've had a couple dozen courses across the globe. They've been incredibly successful. We're happy to talk to you more about the enhancements that we've made, both to the content and to the format and the design, which we're really proud of. We're really excited about what it brings. It's about 3 years in the making. more than 200 volunteers, and it's been quite a task, and again, really proud of what it's turned out to be, and look forward to all of you teaching and taking ATLS 11 in the coming years. Oh. I'm sorry, I don't know what I'm doing wrong. There we go. So this is Committee on Trauma has an annual meeting in March, and we combine it with what I referenced earlier, the Global Symposium. And what we've done over the last couple of years is try to bridge those meetings. This is actually the start of what will be a fairly major revamp of this March American College of Surgeons COT meeting. That will become more of a symposium in the coming years, so we hope to see many of you there. For the time being, the COT, Committee on Trauma, meets for the first part of the week. There's an overlap on that Friday, and then it used to be the ATLS Global Symposium. We're slowly shifting that to the Trauma Education Global Symposium because of the numerous other educational programs that are offered and that people want to talk about their experiences and outcomes with. So you're all invited. This one is in Birmingham, Alabama. How many people have been to Birmingham, Alabama? That's what I thought. So it's a rural part of the country. Our COT chair, Dr. Jeff Kirby, lives there, and it's a tradition when our COT chair is rolling off that we hold the meeting in that person's hometown. So we're really excited to spend time there. So this is a little glimpse of what that Friday, that overlap day, will include. We've tried to identify, Dr. Kirby and the COT leadership have put this together, tried to include topics that are relevant to trauma providers across the globe. Each of these panels will have international, global representation on the panels. So we look forward to that being really a great day, bridging the COT meeting and the Global Symposium. We're really excited this year. I'm sure you've all experienced hearing trauma survivor stories. We have a wonderful trauma survivor, Gary Taylor, who will be speaking. He's from Birmingham, Alabama, and Dr. Kirby's team took care of him after a very serious motor vehicle accident. So he will be there with his family as well as Dr. Kirby's team talking about that experience. I want to point to a number of other programs that the American College of Surgeons offers. We tend to just hear about ATLS 11, but we're really proud of a lot of these other courses. You heard about some of them just before, our ADAM and ASSEC course. And as you can see, a number of others. We're going to highlight just a few of them for you, and again, are happy to talk at greater length with any of you that might be interested. So this is our team course. It was originally intended for medical students, and then what happened is it's like a mini ATLS course, so to speak. Areas that weren't equipped to offer ATLS, didn't have instructors, didn't have the resources, didn't have the space, began offering this course and found it really, really useful. So we just revised it. So this is the 4th edition. It came out about a year ago. It is no cost to the learner outside of the US and Canada. It has a manual and slides with a lot of instructions for those who may not have taught the course before, knowing that it's not always going to be a trauma surgeon or an ATLS instructor who's teaching this course. So highly recommend this. I can also share that it's in Spanish. We are about to load the Brazilian Portuguese and the French, and are open to other translations. I realize not many of those are relevant, but open to other translations. We want this course to reach as many people as it can. We've also moved to an online, an e-team version that we just piloted a couple of months ago. This allows for learners to view the content, the didactic portion ahead of time online, and then to come together in this synchronous sort of manner, knowing that people can't always come together, that they might be spread out, that they might be in rural areas, that they might not be able to take a lot of time. And it was really, really successful. So if you're interested in something like that, we'd be happy to talk to you more about it. This is another fairly new online program. We've learned over the years that in addition to our in-person courses and the skills components which people enjoy so much, we also know that our learners, providers, and trauma team members are looking for online education that's easily accessible to them and at a time that's convenient for them. This is a course that we developed with the Brain Trauma Foundation. It's just a couple hours online. It offers both CME and CE credit. Again, available if anybody's interested. And that's a learner goes and purchases that and watches that on their own through our learning management system. It's not a formal course with an instructor in person. I'm going to turn it over to my colleague, Julie, who's going to tell you a little bit more about some of these other courses. Thank you.
So I'd love to tell you I have 2 disaster management courses. The first one is Advanced Disaster Medical Response. This is the field response to disaster. And the great thing about this course is Dr. Susan Briggs of Harvard ran it in person for 25 years, and we're transitioning it to a fully online course that can be purchased. It highlights her 40 years of experience in every major disaster, and all of the pictures that are included in these modules are personal pictures. So it's very interesting to see. And so right now, we have 7 core modules that are available, and the next optional package that's highlighted in yellow there is coming by the end of the year. Ooh, can I go back? Our second disaster course is called Disaster Management and Emergency Preparedness. So we have an in-person course called DMEP, and then we transitioned that to an electronic version, a fully online version too, called eDMEP. It's very interactive, and it even includes a triage scenario where you walk through 3 influxes of patients coming through. And soon to come is going to be a hybrid version where the students do eDMEP online, and then they come in for a tabletop exercise. We have a Rural Trauma Team Development course. This course is now, we're going through a 5th edition revision. It is focused on team development in a rural environment, really focuses on a 3-person team. A clinician, a nurse, and any other health care professional around. So that is launching in March. We do have a surgical skills instructor readiness course. For some of our courses like ADAM and ASSET, we have instructors who are not ATLS instructors, but still have very valuable experience, such as a vascular surgeon and whatnot. So we are creating a fully online, short, about an hour, 2 hours, instructor course that they can take. All the content is from the ATLS instructor course. So they can go through this asynchronous on-demand lecture and then teach a course as an instructor candidate, and then indeed become an instructor for that course. So as Alisa was saying, ATLS is turning 50 in 2028, and we're extremely excited about that and very proud of it. And we are looking for stories from around the world of how ATLS has impacted you, impacted your patients, and what you've learned from it. So the My ATLS app, it currently exists with the 10th edition content, but I'm very happy to say that next week all of the content will switch over to 11th edition content. There will be 2 versions of it. There's a complimentary basic version for all users that includes these in-depth chapter summaries that highlights all the key points from that chapter, and the resources, which includes tables, checklists, interactive algorithms, and some calculators. Now there's a pro version that adds onto that the videos, the skill stations, and some flashcards and quiz questions. And the great thing about this app is it's, obviously trauma content very easily accessible when you need it, but we're also continuing to add content. So we call them Trauma Tuesdays. Every Trauma Tuesday, we are releasing new content on the app. And anyone who currently has the app When it transitions to the 11th edition next week, we'll get 6 months of that Pro version free, and we're working on getting 2 months of ATLS learners getting the Pro version. So this is just was interesting to me. Of the people that have downloaded the app so far, ATLS is split into regions. As Australasia is region 16, and it's great that 13% of total downloads are from this region. And as you can see, it's a steady, constant download. So we're very excited about that. We think there'll be a big jump once ATLS 11 content is released next week. And we just wanted to say we're very honored to be here. And we wanted to thank all of our global partners. We couldn't do what we do without you. And that we're here. We're here to help support you in anything trauma education. Thank you.
Thank you, Ms. Cwik. This is extremely informative. I'm sure you have lots of pressing questions, but we can leave them to the end when we have plenty of time to discuss amongst our panel and with the audience. Now, let me invite the third speaker for today, for this session, the fourth speaker for this session, who is Dr. Zhenqiang Gu, who is the Vice Chair of ATLS Malaysia. He's the Head of Surgery at Tanjung Karang Hospital in Selangor State in Malaysia. And he's going to talk to us today about how the concepts of ATLS support the development of rural surgical services in Malaysia. So, Dr. Gu.
Thank you, Simon, for the kind introduction. Very good morning to everyone present. While waiting for the slides to be set up, can I just have a quick show of hand? How many here in the audience are currently still in training? That means you're a resident, you're a fellow, you're trainees. Hands up. Okay, that's probably 30% of the audience here. So I was just like you 3 years back. And today I'm going to share with you how the concept of ATLS supported the development of a rural surgical service in Malaysia. I have no disclosure. So these are my presentation outline. I'm going to talk to you about the area of coverage of my hospital and how the ATLS philosophy in context, and how did I translate the concepts into building of the system, and what I did to build capacity through phase expansion in my hospital. And we're going to review a bit of the milestones and data on the things that we have done in Tanjung Karang Hospital. So this is a map of Malaysia. You can see we're surrounded by Thailand up north, Indonesia down, with Singapore and Brunei somewhere in between. The map that is in beige in color is Malaysia. The one that's maroon is the state that I'm practicing. And that is actually the most densely populated state in the Peninsular Malaysia. So on paper, ideally, you should have one surgeon to 100,000 population, 100 to 120,000 population based on WHO's criteria. Now, if you look at this map, this is how on paper Malaysia has been divided into different areas. And the dots that are in blue are the tertiary hospitals, and the dots that are in pink are the rural or district hospitals. So they have certain facilities, and these pink dots there are 32 of them. And 3 years back when I graduated, they sent 32 of the freshly graduated surgeons to each of this center to be the single surgeon in those centers. So this is the state that I'm practicing in. You can see Hospital Tanjung Karang somewhere up north, and the surrounding hospital as the referral center that we send a different subspecialty to the different subspecialty of surgery. And this is the distance. Okay, I'm so sorry, so small. Okay, anyway, it takes my patient about 90 minutes ambulance ride for tertiary care. And henceforth, there are a lot of things that we need to do in where we are. So this is a distribution of the number of surgeons. We have 74 surgeons in our state, the state of Selangor. The population in Selangor state is 7.1 million. On paper, there is a good surgeon to population ratio, but the hospital that I cover, the area that I cover have 400 and 2,000 population, this by the national statistics. So actually on paper, we are having a lot of more patients than the number of surgeons that we would like to. So this is a picture of the hospital. It was built post-World War II by the British, and the picture in the middle is the old hospital building, and the picture on the right is the new hospital building. Now the building looks fantastic, and what do you think the patient's perspective would be if they pass by a hospital at that size? They would expect that they would be able to get a comprehensive care in that hospital. They would expect that the equipments in the hospitals are ready. But sometimes that's in the ideal situation, and that may not be true. So in February 2023, after I finished my training, I was sent to this hospital as the sole surgeon. They gave me 5 junior medical officers, 22 beds under my department. There were general radiograph, ultrasound machine, but there were no laparoscopy, no endoscopy, no ICU beds, no CT scan. And the operation that was allowed by the covering surgeon, covering consultant, was GU. You go to Tanjung Karang and you do appendix, hernia, and put in chest tube for rib fractures. The rest you send to us. Yeah, but I have mixed opinion and suggestion, and we started doing a bit more surgery as they passed. And 2 months after I started working there, we loaned an endoscopy system from a company, and we are very grateful that they provided the system. Because what we did was, with that system, we performed some endoscopy, we collected data, we sent it to the policy makers, the decision makers, and we get some funding to purchase our own scopes. Right, so these were in the early days. This is a junctional injury in the groin. This is on a good day. Patient is stable. Looks like something that I can handle, but I'm not sure whether in the lower abdomen, whether the bladder was involved, the rectum was okay. So what we did was, we didn't have CT scan, so we needed to inflate the bladder through the Foley's catheter and see if there's any leakage of fluid. If there isn't, there's no major bladder injury. And that's the scar after it was healed. And I did not have drains, so we were using nasogastric tubes as drains. This was on a bad day. That's where I grew a lot. There was a posterior penetrating injury. Oh, I'm sorry, the blade can't be seen. There's a huge blade there in the center of the abdominal X-ray. So when a patient was unstable, brought to the theater, though it was a posterior penetration, open it up. There was some hemoperitoneum, but there was no bleeding in the peritoneum, and the tip of the blade was jutting out at the splenic hilum and just above the kidney, and there was a zone 2 retroperitoneal hematoma. Now, we just started there in the hospital. I only have 2 pints of Safe O. I got no Satinsky's clamp. There was no ICU bed. I had to call for help, right? So, long story short, it took us 4 hours until the patient was accepted by another center, and it took a total of 12 hours until the patient was re-explored and the blade was removed. So from that experience, I told myself, right, now you place a surgeon there. I was trained to do certain things, and there's a lot of limitations in this institution. I need to be prepared for rainy days, and there's no more consultant to hold my hands, right? The best thing that I could do is a phone call, and I need to make sound decision, otherwise patients will die, right? So ATLS philosophy, now I think a lot of us here are familiar with it. It's a systematic and prioritized approach, and we have changed it from ABCD to XABCDE in the 11th edition. We do most with what we have. You have to have teamwork with role clarity, and you need to have continuous reassessment and improvements. So having teaching ATLS for a couple of years, these principles I realized it can be applied in developing a new surgical unit in a small hospital. So we started buying equipments, procuring laparoscope, endoscopes, bought some consumables, sent my medical officers for training, going for workshops, conferences, let them see what the rest of the world are doing, what should a general surgical unit should be capable of. So this is our admission data. In a rural setting, I can't be just doing only trauma, and I can't choose. Many a times when I arrive to the hospital, the elective list, I have to think oncology, and then late morning, I have to think physiology when I'm doing operation for trauma. And in the evening, there may be difficult discussion for palliation and things and so on. So it was a lot of responsibility on a single person, and that's the distribution of the admission data that we have. So this is the milestones that we did. Our journey started from a single surgeon, and 2 months later, we have loaned some endoscopic and laparoscopic instruments. Half a year later, there was 2 ICU beds. And then towards the end of the first year, we have bought our own equipments, because 6 months passed, we collected some data, and we said, I really can't provide the comprehensive care if I don't have the enough equipment. And with a lot of requests, the second surgeon came 1 year after I was there, on call for 365 days. And yeah, there it is. That's our journey. And the CT scan just came probably more than a year ago that we have the CT scan installed in our hospital. Now, I looked through the journey that we have, and we like algorithms, we like ABCDEs. So if I were to put the process of developing that unit in A, B, C, D, and E, A would be first thing you have to assess is access to the basic surgical care first. So the health clinic around my hospital, we have 15 primary healthcare clinics, and this probably about 20 primary care physicians are working around the region that's providing care for that 400,000 population. I opened the floodgate, and there is no formal referrals needed if they were to send a patient to my clinic. Just a referral letter and walk in, they can come in anytime. And we build confidence through training, that's B. C, we need to create referral pathway. You need to know who to call, who's gonna be the person that's covering you, what services you can't do at your place. And D, data collection on audit. And of course, when you are ready, you can expand the service gradually. So when we progress, when policymakers and head of services visited us and they saw what we were doing and we garner more support from them, we organized a local regional conference among the primary care practitioner. Cape Coral is a direct English translation from Tanjong Karang. It means Cape Coral. So yeah, 4 Cs there, Cape Coral Cancer Conference. So it was quite fruitful. We had the state health director joining us and given us her support. And with that, we also have results. We have Pink Ribbon Clinic. If a lady with a suspicious breast lump come to our hospital, triple assessment within the same day, if possible. Right, so that's what we achieved with the support from the administrative side. We managed to, and you can see the dark blue bars are the post Pink Ribbon Clinic initiation, and there is a stark increase in the achievement of the key performance indexes that we set. And if you see the column on the right, when we mentioned about oncologists, histopathologist, breast surgeon, reconstructive surgeon, palliative care specialist, those are things that we don't have, right? But we still can run a comprehensive Pink Ribbon Clinic, able to offer care for a lady with breast cancer. So this was a visit by a professor of colorectal and rural surgery from the University of Alabama. I'm going to meet him again next year during the global symposium. So when he came and he would learn of our work and our system, and we both agreed that the rural surgical development is less about money and more about mindset. which the same mindset ATLS has instilled in generations of trauma surgeons, and we both think that holds a lot of truth in it. Now, so what are we doing after that? So you have a lady who come in with a groin hematoma at that huge hematoma over there. We did a CT scan. There was a pseudoaneurysm of the common femoral artery. The neck was small, tiny hole, open up. That was the pseudoaneurysm, removed it, repaired it. Post-op, there was, because of the hematoma, there was flap necrosis. Had to close it up with a local flap. So, and that's SMA thrombosis with bowel ischemia. So when you have developed and you are ready to progress, and your team is, they are ready to help you, you can do quite a lot of service to the local population over there. So this is a patient who came with right leg fossa pain, 40 years old man. Junior medical officer saw him initially with the impression of perforated appendix, admitted to the ward, did a CT scan the next morning. There was a SMA thrombosis, brought into the theater. It was dusky from from 30 cm from the DJ flexure all the way to the mid transverse colon. The initial surgeon who went in wanted to just close up and, you know, let's call it a day. But with that CT results, we did a SMA thrombectomy and then resected 100 cm of the small bowels, put laparostomy, and went in after 48 hours, primary anastomosis. The picture down there was the picture 48 hours after that. Not a single drop of TPN was given to the patient. Patient was well, went home. Huge perianal tumor, did a local flap. The picture on the right was post-completion of CCRT, and he's in remission. He's a farmer down there where I'm working. This is for Dr. Prita. Right, so I just had a chat with her yesterday evening. She works in the oncology oncology center in SGH. And this is a duodenal sarcoma. Patient came in with duodenal obstruction. You look at the specimen down there, it's a wide local excision of the en bloc resection of the whole thing. It was a distal pancreatic, duodenectomy, splenectomy, sleeve gastric, left hemicollect, and a reconstruction using a D2 DJ. R0 resection, HPE came back, pleomorphic spindle cell sarcoma. The had an MDT, oncologist didn't know what to do with it, asked for watchful waiting. This is case number 3 in the world, we are writing it up. So this is just last month. Now we have 2 general surgeons, 7 medical officers, same number of beds. We have general radiograph, ultrasound machine, CT scans. Now we have 4 ICU beds, always fighting with the medical colleague who should go in. Endoscopy, we have sets, we have laparoscopic sets, we have bought more tools, and this is the distribution of the caseloads that we have. We probably would include cholecystics and appendix. We are probably in the abdomen once or twice a day. Yeah, that's quite a high load. Those are our post-op complications. It's comparable to the other centers. This is the total number of scopes that we have done, 5,100 up to June this year. So these are our milestone. We saw a total of 23,676 patients in our outpatient clinics, FNAC core biopsy done. We did big, small operation, 2,218 cases, of which there were 14 post-op mortality cases, which all were emergency cases, 0.6%, which is comparable to a lot of the other centers, big centers in the world. We treated 5,000, close to 5,000 admissions, transferred out 700 patients, and of this transfer, they were of neurotrauma, endo-euro services, and ERCPs for CBD stones. We had our cancer registry documented 453 patients because we are running biopsy services, so we are following up on the patients with lymphomas, thyroid, breast, colon cancers. Yeah, so that's what a rural surgeon does. You technically do everything. We have our access for dialysis services started about a year ago, so we have about 89 patients now. created 41 native AVF, and our successful cannulation rate for BCF is comparable to the vascular surgeon. RCF has been poor, and we think that's because of patient selection. We will improve on that. So let's go back to the ATLS philosophy, systematic and prioritized approach. I think we did that. We really did the most with what we have. There was a good teamwork with the team that we formed there in Tanjung Karang, and you can see the numbers and the data. There is really continuous reassessment and improvement. Now, right, you see Narayan there? That was 2 months ago. He taught me DSTC. He came to Malaysia. There's a DSTC course. It was a very nice course. So Narayan said 10 years back, Scott taught him. So 10 years later, he taught me. And this is a testimony of that course, because after attending that course, we had a thoracotomy. You see the other patient with a huge left perinephric hematoma. The kidney is now in a histopathological lab 90 km away from our hospital. But these were all done there, and because of the high numbers of ERCPs that we send out, once a week I go to another center to learn the procedure, so that I can keep the patient in my center and do it there for those straightforward cases. So thank you. That's the end of my presentation. That's my contact. Yeah.
Thank you. Thank you, Dr. Gu. Let's give a round of applause. Please take a seat. Please take a seat on the panel. And now we are open for questions from the floor. Any questions for our very enthusiastic and learned experts? I have, may I start then? I have a question for Dr. Kurti. Yeah, regarding the latest changes to the new ATLS 11th edition, how would you like to implement the upskilling of the faculty in Sri Lanka?
Yes, actually we had some discussions between our faculty as well, how we can go ahead. We decided we will implement it from 2026. So before that, all the instructors are supposed to do this online accreditation, and we are hoping to get some information from this gathering, the ATLS gathering, how can we go ahead, and our educator, Dr. Pandula, is on planning to have some sort of a day workshop or something somewhere in December before we embark on the 11th edition. So that's the plans for the time being.
Thank you very much. Yeah, sure.
From Alicia, can I ask a question? Now, you have so many new courses developed from the ACS, and some of them are overlapping, like the asset course, the exsanguinating hemorrhage course. So would that be some sort of confusion for the students, what to select and what to, are they compulsory, or who would select these courses, and how would they select a trainee, if I may?
That's a great question. Thanks for asking. So in terms of what's required, at least in the United States, there are some institutions that will require a course, and sometimes a state. But otherwise, it's really left up to individuals and employers. The asset course is a really, really wonderful course, which you heard about earlier. You have to have access to cadavers, so a lot of countries that would like to offer it aren't able to gain access, and in the States, some of the prices of cadavers have really skyrocketed. So sometimes it's around what resources one has to be able to offer the course. We always try to encourage people to try out the team course, because it doesn't cost very much, and it's at least something that we can get out to providers and teams. So I don't know that I have a perfect answer, because it's up to people's interests, it's up to their specialty, it's up to some requirements that might be in place. But always happy to talk with folks about what each of the courses offers, what it takes to teach, and what sort of learners might be interested. Not across the in the U.S., not across the country. Some residencies will require, most residencies require ATLS, and a few might require some of the others, an ADAM and asset, but not, we can't speak kind of across every single state or every single country. I don't know, are any of the courses required in your countries or training programs?
For Thailand, we need to have the ATLS.
ATLS in every general surgery program, yeah. Same for Sri Lanka, yeah. Malaysia? Any of the courses required for learners?
We don't make it compulsory, we make it recommended. Yeah, but the uptake is still quite a lot of them who join in. Yeah.
In Hong Kong, ATLS is compulsory for general surgeons. They have to take ATLS before they take the exit FRCS exam, which is the board exam, at the end of their training.
Because we are among the developing country, same as in Thailand, with the graduate from medical school, they go out in the rural hospital. So if they would like to have the ATLS, they have to come back for get training to be a resident. Sometimes it's too late. So I talked to my team from Thailand. We used to have the team course by just purchase a manual and teach them, and we have a course light. But now you move to with the E-team course. So could you give us this room that how can we adopt that E-team to our country? Or just talk to you, or you have to have any kind of standardized or something or not?
Yeah. To bring team in, yeah. So the traditional team is still available, and we always recommend in-person, both didactics and opportunities for skills. So we haven't gotten rid of that. The E-team was really intended for reaching individuals that can't get to a site, or being able to reach a large number of learners who might be spread out across a country or state. So I think again, in person is probably always preferred, but a lot of our medical schools do use it, and we're just starting to play with this idea of this remote E-team. Yeah, hope that helps.
And we need to have the site visit or not, or just register to you and we can bring it in to our country.
Say that again?
Is it necessary for you, not the same as ATLS, you need to write the MOU agreement or something, but for the team course, if some country here would like to adopt in the country, how can they do it?
Yeah. Thank you. Sorry, I didn't understand that. So ATLS is the most rigorous in terms of getting it approved and having appropriately trained course directors, et cetera. So team is, we try to be as flexible as possible. So there's not a contract. You can reach out to us, and you need one person who's going to kind of be the champion. And then after that, it's the manual provides exactly what you need for a course director and for instructors, but the requirements are really as flexible as possible to make sure that it can reach as many people as possible. Yeah.
Yeah, so I think the region, we can help each other out, especially those countries who have already got the courses started. That's what we can learn from each other, how to start different courses. Back to you, Sam.
Thank you. I have a question for Dr. Gu. It's really amazing that you managed to start everything out from scratch, and you've started the endoscopic program in your hospital as well. I'm just wondering, regarding emergency endoscopies, do you have any agreement with, are there any gastroenterologists in your hospital who can share some of your workload on ERCPs? Because I find that quite onerous after a while, because once you're competent in doing it, you find more and more indications for doing therapeutic endoscopies. And very soon, I think that it will take up a lot of the workload and a lot of on-call work, and I think that at some point one might feel a little bit overwhelmed. It's certainly the case in my practice, which is in a tertiary center in Hong Kong, but I can imagine that if you're the only experts on this field. I think that you just get called more and more. Do you have any agreements with the gastroenterologists or other hospitals in your area? Any transfer and referral arrangements?
Yeah, thanks. That's a great question. Actually, it's not just for the biliary sepsis. It applies for all cases that you need intervention, timely intervention. And I may be in Sri Lanka attending a conference. So there are pre-made arrangements that a certain hospital would cover. And we always think what happens to the hospital or what happens to the patients when you are not around. But my take is, after 2.5 years there, we should think of what good have you done to the patient when you are around. So when you are not around, even though I always say God will take care of the patient when you're not around, but you have to make pre-arranged agreements and transfers so that someone else can cover for you when you are not around. And I think I would also like to send a message to all the residents and the trainees in the room. You have a lot of people that you can ask for help. You can see the mentors are sitting up here, right up here in the room. There's 1/3 of you in the room. You will feel like you are alone, but you are not alone. Truly, you are not alone, and then there are help out there. You just need to make pre-made arrangements, right? Anyone have anything to add on? Good. Okay, thank you.
Thank you very much. The time now is past 10:30. I'm sure you may have a lot of questions. If you have questions, then I'm sure that our panel of experts up here will be happy to answer them during the tea break. But before we move on and to enjoy our tea break, let us give another big round of applause to our gracious speakers.
This session has truly set the stage for today's conference.
Now I'd like to invite the attendees for the ATLS Region 16 meeting to come up to stage to have a group photo.
We have one more question from the audience.
Sorry. Okay. Yeah.
Stan, and I have a question from Alisa, that we are also having team courses in our country, but the courses are being conducted by several other hospitals. And whenever they inaugural team course, then the news came to me that they have inaugurated team course. Okay, well, good. But what I heard is, because for the team course, instructor should be ATLS instructor. Am I right?
So always ideal, but oftentimes not the case and not possible. So we do not require that you be an ATLS instructor to teach the team course.
All right. And what about, because state chair, because on the certificate it is mentioned the state chair's name, which is like our country state chair, and he even didn't know that he is certifying so many students for the team course. So is there any like MOU, or don't you think that there should be MOU between the state chair even and that body who are going to inaugurate or start team course in their college?
If I understand the question correctly, so your state chair isn't aware of all the team courses that are going on? Yeah.
Yes.
It is less organized than ATLS, and so we can certainly work on that. We hope that the sites would let the state chair know, and the state chair could certainly check our system to see that. But it's a great point and something we should work on.
Thank you. Thank you.
This session has truly set the tone for today's conference. As a gesture of our deepest gratitude for their valuable contribution, we now invite Dr.